Thank you very much for the introduction, and thank you for inviting me to speak at this workshop. And also thank you to Connie for laying the groundwork for this exciting session, PrEP and women. I'll talk about cabotegravir for women, a potential game changer. I would also like to thank my colleagues, Sinead Delane Morelfre, Mina Hossenepo, and Sibu Hosek for their assistance in preparing this lecture. I have no potential conflict of interest to declare. In many African languages, there is a saying that alludes to the fact that women are the core or the cornerstone of homes. Yes, but if women are such a critical component of our communities, of society in general, why do they continue to bear the brunt of HIV? About 18.8 million women and girls are living with HIV globally. And the number of new infections among women and girls every year is very, very high, with about 3 young women becoming infected with HIV every 4 minutes. So this is unacceptable. Yeah. So what is it that we've done for women to curb this epidemic? We know that oral PrEP has been shown to be highly effective against HIV infection when taken as prescribed in a variety of populations and contexts. And we know that the relationship between PrEP efficacy and estimated adherence shows a clear sigmoid dose response. What does this mean? This means that the efficacy of daily oral PrEP remains limited by non-adherence, because we know that in oral PrEP, adherence correlates with efficacy. Novel long-acting products, for example, long-acting cabotegravir, they represent the next generation of PrEP, and they may simplify PrEP use and provide the much needed HIV protection, especially against women in sub-Saharan Africa like myself. Compared to oral dosing, the long-acting injectables are likely to have reduced drug interactions, which are related to first-pass metabolism, and they are likely to have decreased gastrointestinal toxicity. They do obviate the need for daily or pericoital pill taking, and they are administered less frequently, like I said. However, they do not entirely stop or solve the adherence problems. There's also sometimes the need for oral lead-in phase, and the long tail phase may pose a challenge. So an example of long-acting injectables is the novel integrase inhibitor cabotegravir, or CAB, which is an analog of dolutegravir. But unlike dolutegravir, CAB has a long half-life of 21 to 50 days, which allows a once daily oral or a 1 to 3 month injectable dosing using nanosuspension formulation. Yes, so this maximizes adherence and it makes it very tolerable. So let's see how cabotegravir might work. But before we get there, let's look at the HIV life cycle. So HIV binds with the host cells and releases HIV RNA. An enzyme called reverse transcriptase turns HIV RNA into HIV DNA. HIV DNA then makes copies of itself, yes, and splices or inserts into the human DNA using another enzyme known as integrase. After this DNA is inserted into the human DNA, the virus has become a permanent part of the host's genetic material, and it can go on and on making copies of itself. So now let's see how the life cycle is affected with cabotegravir. So let's see what happens with cabotegravir. is in the same body, is in the body. The same HIV coping process begins. HIV binds, you'll see. So here, cabotegravir is in the body, yes, in the host cell. We see that there is cabotegravir there. And then HIV will come and bind with the host cell, and it will release HIV RNA. And HIV RNA will use reverse transcriptase to create HIV DNA. Yes. And normally at this point, the integrase enzyme will come and help the DNA, the HIV DNA, to be inserted or spliced into the human DNA. But when there's cabotegravir present in the body, we'll see that cabotegravir will inhibit the integrase enzyme. As a result, the HIV DNA cannot be spliced or inserted into the human DNA. So this effectively stops the replication or the life cycle of HIV. So now that we understand the mechanism of action of cabotegravir, a novel integrase inhibitor, let's talk about HPTN-084, which is a phase 3 double-blinded safety and efficacy study of long-acting injectable CAB compared to oral Truvada for pre-exposure prophylaxis in HIV uninfected women. Coming to the study population of HPTN-084, a total of 3,224 sexually active HIV uninfected cisgender women were enrolled at 20 sites in 7 sub-Saharan African countries, including South Africa and Zimbabwe. And the women were aged 18 to 45 years. We used a modified voice risk score to identify women at highest risk of HIV acquisition. Participants were excluded from the study if they were pregnant, if they were breastfeeding, or if they had any medical conditions or any other conditions that might interfere with interpretation of study results. And participants were expected to use modern methods of contraception, highly effective modern methods of contraception. In HPTN-084, participants were randomized in a 1-to-1 ratio to one of 2 study groups. One arm received active CAB and placebo for Truvada, and the other arm received active Truvada and placebo for CAB. CAB was administered daily by mouth for 5 weeks, then by intramuscular injection at 8-week intervals after the initial 4-week interval load. Participants in both arms were offered open-label Truvada, initiated a maximum of 8 weeks after the last injection for up to 48 weeks. This is as depicted in step 3 on my diagram here. And the primary endpoints here were HIV, incident HIV infections in steps 1 and 2 and grade 2 or higher AEs. So a total of 4,882 women were screened, and the vast majority of women screened out mainly because of pregnancy, HIV, or other medical conditions. Retention rates were high in follow-up, yes, and I really would like to applaud the team because the team had proactively developed plans to mitigate against the adverse impact of the COVID-19 pandemic. So these strategies really looked at participant safety and staff safety. So there were no major disruptions to study implementation. Hence, there was no need for any administrative censoring of data. Let's look at participant baseline characteristics. These characteristics were similar and balanced between the 2 arms. We enrolled 3,224 participants with an average age of 25 years. And 57% of these participants were 25 years or younger, with 55% of participants reporting 2 or more partners in the month prior to enrollment. And 34% of our participants reported a primary partner who was either HIV infected or of unknown HIV status. The median voice or the median modified voice risk score was 6. And this is consistent with an HIV incidence per year of 10%. So this means that we targeted women at highest risk for HIV infection. Coming to the BMI, 55% of our participants at baseline were either obese or overweight. And at baseline, the rates of curative STIs, especially chlamydia and gonorrhea, the rates were high. So coming to the primary outcome, which is HIV incidence. So in November of 2020, the DSMB stopped the blinded portion of the study because the study objective had been met. And in making their decision, the DSMB looked at 40 incident infections of HIV, over 3,892 person years. And these 40 infections were included in the intention to treat analysis and are infections deemed to have occurred after enrollment. Overall, HIV incidence was low at 1%, indicating that both Truvada and Cabotegravir are effective in protecting against HIV. CAB was more effective than Truvada, with 9 times more HIV infections in the Truvada arm. When we look at the cumulative HIV incidence over time in the intention to treat analysis, women in the CAB arm had an 89% lower risk of HIV infection compared to Truvada. And the 4 incident cases of HIV in the CAB arm showed that 2 were in participants who had CAB injections and 2 were observed in the absence of CAB exposure. What about safety? Both CAB and Truvada were safe. Most adverse events were mild and moderate and balanced between the 2 arms. Gastrointestinal symptoms, especially nausea, were common in the Truvada arm, and 1 in 5 women experienced injection site reactions, with 32% in the CAB arm and 9% in the Truvada arm. Most of the injection site reactions occurred at first injection, but diminished over time. There were no discontinuations due to injection site reactions. Let's come to adherence. In a planned random sample of 375 women receiving Truvada, it was noted that 62% of the samples contained detectable levels of tenofovir, as you can see on the graph at the right. 48% of these specimens had concentrations of tenofovir consistent with daily use. Yes. And as you can see, detectable concentrations of tenofovir were initially high, but they declined to about 53% at about 1 year. And this reflects the challenges associated with daily oral pill taking over a prolonged period of time. Yeah. In comparison, however, injection coverage remained high at 90% throughout the same period. And this highlights the adherence advantage that is conferred by this long-acting injectable product. Moving on to pregnancy, there were 50 confirmed pregnancies over 3,830 person years. However, there were no difference in pregnancy incidence or outcomes by arm. Literature shows that the their problems or their challenges with weight gain in terms of integrase inhibitors. Yes, overall, weight gain did not differ between the two arms. Initially a small but significant weight increase of about 4 kg in the cabotegravir arm, but over time there was a steady linear weight gain in both groups. So there were no discernible differences in changes in weight. The rates of curable STIs were high, especially chlamydia and gonorrhea, and the majority were asymptomatic, which is the case in this part of the world in sub-Saharan Africa. So additional testing is ongoing among seroconverters, looking at the timing of first HIV infection, looking at drug concentrations in both arms, and looking at resistance profiles. So in summary, both agents are highly effective in preventing HIV. CAB was found to be superior to daily oral Truvada in preventing HIV in cisgender women. Both products were safe and well tolerated, with very few differences in grade 2 and above adverse events. Yes, and these results, they complement data from HPTN-083 and confirm that CAB is the first safe and effective injectable PrEP agent for cisgender women. So, what are the next steps after those exciting results? Unblinding of participants is ongoing, and there's a protocol amendment which is in progress. All participants will continue to be followed up, and the amendment will allow continuation on Truvada or transition to open label long-acting injectable CAB. Adolescent studies will provide additional safety data, and HPTN-08 sub-studies will continue in pregnancy and contraceptives. And also there is a qualitative sub-study. So in summary, or in conclusion rather, daily regimen for HIV prevention and treatment, it remains an irrefutable and arguably insurmountable barrier to adherence. But long-acting injectable cabotegravir is a potential game changer. It may result in the expansion of HIV prevention package for cisgender women like me and all over the globe. Yes, and additional safety data is being collected as we speak. With all this exciting news, there is need for a supportive organizational and policy environment to allow rigorous national scale-up of CAB delivery to deserving and needy populations like African women. And coming back to African women, let's not just give them options, but let's give them choice. And outside of CAB, let us continue to prioritize other novel drug delivery systems with long-acting approaches. For example, long-acting oral islatravir, which my friend Connie here can attest to, as well as implantables and other multi-purpose prevention technologies. So with that, I say thank you.